Okay. So thank you everybody for being here for Gilda's Club Madison's What's New in Melanoma Care at workshop. And thank you to Dr. Gloria Xu and Dr. Mark Albertini for presenting today. Our format will be, each of them will have some time to do their presentations, and then we'll turn off the recording and allow questions from the audience. So thank you both for being here. And with that said, I will turn it over to Dr. Gloria Xu. Thank you.
Okay. Good evening, everyone. Thank you very much for the invite. You hear me okay, right?
Yes.
That's great. So for the next 20-25 minutes or so, I'm going to talk about the first part of our joint presentation. And Mark and I have been doing this, I don't know, it's like the 4th or 5th time now, but I think the last time we did it was like 2017. So it's been a while. It's good to be back, talk about what's new in melanoma care today. I think a lot of new information you're going to hear from Mark later in the second part of presentation. I'm going to cover safety in the sun, how to use sunscreen correctly, and kind of emphasize sun protection. If I have time, I can also quickly go over some brief overview of some skin cancer presentations. But my part of talk is essentially pretty basic, and it's more sort of a reminder than giving you a lot of new information. Mark's presentation will be more exciting with new development. I don't have any conflict of interest, so my goal is to just kind of help you guys to recognize the UV rays, carcinogenic energy of UV rays, and talk about how to use sunscreens correctly in some skin lesions that are suspicious for skin cancers. If I have time, I can go over some pictures. So a quick review of UV type. You probably heard about that. There are different subtypes of the UV rays, UVC, UVB, and UVA. UVC is really short, between 200 to 290 nanometer, and that's reflected away. In the sky, basically, it doesn't really affect us. It's so short, it reflected away. UVB, that will reach the earth and penetrate skin, but it's in this wavelength, it just penetrates epidermis, which is paper thin layer of the skin. It doesn't go deeper beyond epidermis. And the UVA is 320 to 400. That's a long wavelength UV. That is actually dangerous because it penetrates all the way down to the deep dermis. And to look at that more carefully, the UVB, it will give you immediate burning sensation. So if you go out in the sun and a sunny day and you feel burned, that's from UVB. It's blocked because it's a shorter wavelength. It's actually blocked by your car window, your house window. It carries high energy, and that can cause direct DNA damage. Now, they both can cause DNA damage. UVA, it's longer. It causes more kind of long-term persistent DNA damage. It causes tanning. So, sometimes some people might have experienced like, a few days later, you look like your skin's tanned. That is more from UVA, and it penetrates glass, window glasses. So that's why you cannot feel safe if you're within a car, right? WHO has already identified UV rays as carcinogenic substitute. Basically, it can cause cancer. Now, when we have in-face presentations, I usually ask people questions, but now we just kind of look at the question and we can make a guess in your own mind. So I try to kind of remind you guys, like most of the UV rays reach Earth is actually the UVA component. So actually 90% of UV rays reaching Earth are UVA, and that causes more persistent DNA damage, as I said. And the common things I remind my kids too, that people sometimes feel like, oh, I can just keep my sunscreen in the drawer in the winter time because I only need to use it in the summertime, which is not true. And in cloudy days, my boys will say, hey, I'm gonna play tennis without sunscreen because there is no sun, which is not true either. So if you look at the details, Okay, I'm gonna give you answers right away. So over 80% of UV rays penetrates clouds. So in cloudy days, you still have a majority of UV rays actually kind of working on Earth. And I also like to ask people questions about reflection. So, you know, in certain days, a certain surface will reflect UV rays, and that cause more damage. And surprisingly, snow being so white, it reflects 80% and more than water and sand. So when you go out skiing, definitely think about sunglasses and sunscreen on your face if it's not protected. And one quick word about indoor tanning that is more relevant to young girls, you know, those beautiful adolescent girls, and they really want to get tanned. And that carries a lot of damage because all the tanning baths, they actually have a mixture of UVA, UVB, and it's 15 times more potent than, you know, just sun rays. So definitely keep that in mind. So I'm gonna move on to sunscreen. Like patients always ask us, you know, hey, how do we choose what kind of sunscreen? How do we choose sunscreen on the market? There are so many brand names. And our AAD has really good website and it's very easy to follow. So actually the most important thing is that you use it, right? So when you choose from the market, you just remember that you want a SPF sun protection factor 30 or higher. Because if it's 30, it's already blocked 96.6, like close to be 97% UV rays. And you want a broad spectrum. Years ago, you actually have to read small prints on the bottle to say that what kind of ingredients will block UVA, what kind of will block UVB. But I think 2 or 3 years ago, it's FDA actually had a unified labeling. So if the sunscreen has a broad spectrum, which blocks both UVA and UVB, it says broad spectrum. If it doesn't say broad spectrum, it probably just works for UVB, which you know that won't penetrate the glass, but UVA will. So you want to look for this broad spectrum. And if you actually sweat a lot outside, and if you do some water sports, you want to look for water resistant. There is nothing waterproof. So, you know, water resistance, the bottle will tell you you have to reapply in every, you know, 40 minutes, 80 minutes, something like that, you know, 1 to 2 hours. So those are the important things you keep in mind. And the brand name is really not the most important thing, you know, and it also comes with different formula, you know, some with gel, some with a spray, some with cream. That is also your personal preference. And a quick thing to remind you guys is like a SPF 30 is not twice as good as SPF 15. Because 30, as I said, it blocked 97 percentile, and 15 blocked 93 percentile. So once you kind of, you know, above 30, close to be 100% almost, but nothing is 100%. If you have sunscreen SPF 100, and that's on market now, I don't know if you guys seen it. It is on the market. There are some products SPF 100, but that doesn't mean you can block or filter sun rays 100%. It's 99%. So, you know, once it's above 30, it's 97% versus 99%. So it's marginal benefit. That is why FDA, or not FDA, our academic, you know, our AAD, American Academy of Dermatology, just say that if you can find 30 or higher, that's good enough, right? So I already give you an answer about that. So we have excellent guidelines by AAD website. If you just go to, you know, www.aad.org, you just type in keyword like sunscreen, it'll give you a lot of good information just for people, not just for clinicians. So other means of sun protection, of course, it's common sense. We all know that we want to seek shade. You can really wear some colorful UV protected clothing nowadays, long sleeves and pants and broad brimmed hat, sunglasses, of course, and try to avoid midday. Because midday between 10 a.m. to 2 p.m., there's most sun ray reaching the earth. And try to drink a lot of fluids and keep hydrated, things like that. Again, common sense. And I also want to put a quick slide about vitamin D, because I think that many patients will ask me in the clinic and also, you know, in the lectures as well, what about vitamin D? People are worried about they might have vitamin D deficiency. As we all know that vitamin D, you can absorbed through sun exposure, and it's also very important for bone health, skeletal bone health. But the consensus nowadays is we believe the vitamin D you got from the pill or from your food is just as good as you got from the sun. So if you can just, for recommendations like for kids and for adults and for older people, if you can get this IU, your international unit, you can this amount through your daily intake, you're good. Your bone is healthy, and there is really no need for you to sit in the sun and get vitamin through that way. Then I'm gonna switch gear and talk about for melanoma. It is, again, Mark is gonna talk more about it, but melanoma, even though it's only about 1% of skin cancers, but it causes more than 75% of deaths from skin cancer. So each year we see a huge number of new melanoma incidences, both in men and women. And this paper actually kind of illustrates nicely that if you see melanoma, say like a very thick melanoma, 4 millimeter, versus melanoma pretty thin, 1 millimeter, and that's the depth, microscopic depth of melanoma, not the visible depth. Microscope that pathologists can measure for you from the top of the skin to the deepest tumor cells in the specimen. So if it's really thin, the people look at the survival over time, over years of time, the survival rate is pretty flat, meaning that they survive pretty well. Versus if you have really thick melanoma, the survival curve drop dramatically. Thick melanoma, they have more chance to spread to lymph nodes or distant organs. So if you look at this quick number here, 5-year survival. If you localize, meaning that it's thin and very early melanoma, your 5-year survival rate is close to be 100%, pretty good. If you have lymph nodes, in the regional lymph nodes, metastasis spread already, it's 60%-ish. If you have distant organs, it's kind of close to be 20%. And this is a patient I shared with Mark years ago. The patient actually had a metastatic melanoma, just kind of spread to the skin. So if you get to this stage, it is pretty devastating. So that's why we really want to teach people to identify, your changing moles or new moles very early in the stage. If it's early diagnosis, it's basically cured, right? So there are a lot of teaching about how to identify melanoma. And I have to admit that still this ABCD rules, you heard about that, and we added E, ABCDE. It's not going to capture every melanoma, not even for clinicians, right? But it's something for you to get started. You look at a mole, you look at if the mole looks kind of symmetrical or asymmetrical to you. At the border, if the border is irregular, zigzag, color, different shades of color, diameter, usually we say 6 millimeter as cutoff, but we've seen really small but deep melanoma. So it's relevant. It's basically relative for the diameter. It's not really absolute. And E is basically saying that over time you see evolving, right? If you see a mole looks like this, definitely, if you photo document yourself, now you have cell phone, you have, very easy that you can take a picture of a suspicious mole yourself or have your family member do that. And if you line up, but you don't have to print them out, right? You line up, you look at it, say, wow, this is really changed over, months or years period of time. That mole needs to be out, needs to be excised and tested under microscope for pathology. So those are common guidelines. And then we also talk about for patients who have tons, some people have tons of moles. They have so many, it's really, you cannot really cut every mole out. So we look for something called ugly duckling sign. So basically 1 or 2 moles, they stand out. They just don't look the same as the rest of the moles. And we typically kind of sample those as well. And some of the real patients, I'm doing okay with time. Some of the real patients, like if you look at it, this is a melanoma in situ, that you look at it, like the ABCD guidelines, you can see irregular border. You can see 2 shades of color, more than 2 shades, right? Brown, a little dark brown, a little pink, and maybe kind of losing some colors. Sometimes we call this regression. Some melanoma can regress. and they look like they're losing some color. So this is bad enough. So we did a biopsy. And this is another one that you have 2 shades of color, like brown and pink. And this is actually biopsied by a primary care doctor and referred to me for a complete removal. And it's pretty clever that if you don't want to cut the whole thing out, you just sample, you know, the junction of these 2 colors. This is another melanoma that I took care of that, again, the color and the shades, you know, you can see it's pretty suspicious. And I did a excisional biopsy, just take it out and sample the whole thing and look at the depth, so we can stage the melanoma, look at depth of it. Some of the melanoma patients we deal with is really tricky because it's on the face, it's on, you know, anatomically sensitive location, like this woman's. So the biopsy, if we do a biopsy, we obviously don't want to cut the whole thing out. We will probably pick the most palpable, the thick part of the lesion. So this is like more like palpable. We call palpule, like palpable components. So we take this out and test it. So some of the melanoma, when we do the testing, we don't get the whole staging information because they didn't get the whole thing, right? So all this we have to keep in mind. Now, some of the pigment lesions is actually pretty tricky, even for us, for trained eyes, like which one's melanoma, which one's not. So, you know, if there's change, there's suspicious index and there's any doubt, we will biopsy it. So like, for example, this one is melanoma, one is hemangioma, which is like a vascular growth. And this one is a hemangioma, this is melanoma, 1.1 millimeter already. It's a past 1 millimeter cutoff. Now, again, this is a very dark growth, and this is a very dark one as well. One of them is melanoma in situ, one is just pigment seborrheic keratosis, which is a benign thickening of the skin. So this one is actually seborrheic keratosis. This one is melanoma in situ. This just to show you that, you know, for lay people, if you, you know, have noticed something like dark and something new like this, you don't sit on it. You want to show to your doctors, right? But some pigment lesions that, even though they look suspicious, they're definitely still okay. Like this one is a 20-year period, like sort of a congenital pigment lesion, and gets a little bit darker, but you can see the edge is still pretty, border is pretty even, and there's 2 tones of color, but they stay like that forever. So I did a biopsy. It's just a benign mole. We call compound nevus. It's a benign mole, and some of them is pigment lesions is not really melanoma. It's still, you know, still needs to be taken care of, but it's not as bad as melanoma. Like if you have this pigmented basal cell cancer, they have a little bit of shiny appearance. Again, I'm going to show this case I share with Mark to show you that for patients with history of melanoma, and we definitely treat them as VIP patients, right? If they have anything that looks suspicious, even though it's not really clear, not obvious, we want to see them. We want to do biopsy if needed. And then this is a case Mark sent to me in the clinic, say, hey, this patient with you can see a really long scar from melanoma removal on the upper back and posterior neck area. And Mark saw the patient that day. It was a few years ago. I don't know if Mark remembered. And Mark called my office to say, hey, this patient actually noticed a small lump underneath the skin. There's nothing you can see on the skin. So it's right there. Of course, like I marked it because I palpate the patient. Like on the screen, you won't be able to notice any difference. So there's a little kind of lumpy, bumpy, deep component there. There's no pain. So I had a fellow working with me, a trainee working with me, and we cut through and pop some, you know, fatty tissue out. And she's like, it looks kind of just like a normal fat. I was like, getting deeper, digging deeper. So she got a little bit deeper. And it looks like there's, maybe it's a shadow, maybe it's pigment. So we both look at it and cut deeper. Guess what? That's melanoma. So, and I actually had a couple of cases like that. Since this case, I was like, I always teach my residents and fellows, like for patients with melanoma, you know, if you notice some we call subcutaneous, basically underneath the skin, if subcutaneous nodule, you really have to do deep biopsy. If you do, you know, semi-deep biopsy, I mean, I think the first thing she pick out is not superficial. I would say still okay, but you don't stop there. You want to dig a little bit deeper. So that is actually subcutaneous melanoma mets, right? Basically, it's metastasis to melanoma, underneath the skin area. And then in 5 minutes, I'm gonna quickly show you that there, because sun rays actually cause melanoma as one of the major important factors to cause melanoma, and also cause non-melanoma skin cancer, as we all know, right? And non-melanoma skin cancer, in terms of incidence, it's much more than melanoma. So it's also very important for you guys to think about some protection and think about how to recognize non-melanoma skin cancer. For example, basal cell cancer, we have different subtypes clinically. The most common things you can see is this kind of shiny, it's a shiny bump. It looks like it just kind of, looks like there's some water in it, but there's no water, it's firm. So it's not a blister. And, you know, but it has a little bit of a translucent, shiny appearance, and that's typical nodular melanoma, nodular basal cell cancer. Some of them has a little bit of an umbilicated center, because they started kind of become necrotic, the tissue, you know, the tumor tissue become necrotic and form a little bit of a depression in the center. That's also very common. So you can see shiny and a little bit of a ulcer. And this one, you know, have a little bit of scab because the center gets a little necrotic. You know, this is basically doesn't look like there's anything there other than just a scab, you know. Some of them could be very, very little. So pay attention to some new growth. And this is very shiny, but a little bit flat. And some of the basal cell cancer could look like a rash. So if you look at it, it's a pinkish flat. And it could be a little itchy even. So, you know, but superficial basal cell cancer, it's not dangerous. Like, they don't really spread. It's just, you still need to take care of it, right? And some of them so subtle, like that. Okay, so I'm gonna actually move on to squamous cell cancer. So for squamous cell cancer, initially you can have a lot of, like, what we call AKs, or actinic keratosis, which is some damaged precancer skin. Like if you look at farmer's face, you can see all these like sandpaper-like rough texture, reddish, you know, and kind of confluent sometimes, like connecting to each other. That's very commonly seen, and sometimes it's just kind of a little bit of rosacea, a little bit of a dry skin, but it's commonly seen as a precancer actinic keratosis. You know, sometimes it's really hard to tell which one is actinic keratosis, which is squamous cell cancer, because actinic keratosis is the precursor. About 2 to 10% of AKs will turn into squamous cell cancer. So clinically, they do actually, it's within the same spectrum, they do have similar presentation. So I'm gonna show some of the squamous cell cancer could also pick up some of the pigments. So they can look like brownish. We call pigmented squamous cell carcinoma in situ, or Bowen's. Some of the squamous cell cancer is really more obvious. You can see like that's bumps, right? We call nodules or plaques. They like bumps, and they open up, they become painful, like this. So, you know, you're not going to ignore anything like that on your skin, right? They look like it's just ulcerated and, you know, painful. Like they look like a kind of exophytic, like they above the skin, really grow above the skin. And then you really don't want to wait until this stage. So like if you see a tumor sitting on your cheek like that, this patient already have lymph node, positive lymph node through CT scan. So, and that's another very devastating case, that this is a man with a primary SCC on the heel, and that was many years ago case. So it was cut it out and by plastic surgeon colleagues, and then it was beautiful graft, but then very quickly the patient developed lymph node metastasis to the inguinal lymph node, and got a lymphadenectomy, and this is from free flap surgery. So put a free flap, you know, like borrow some skin and put it on there, and then just and this is done actually in Mayo Clinic, and just about a week after that big surgery, he popped out all these skin cancer. All these bumps are squamous cell cancer. So it's squamous cell cancer is, we usually say 5% of them can be pretty aggressive, versus melanoma, I mean, the percentage is higher, but squamous cell cancer, 95% of them, we treat them really, you know, we cure them, but about 5% of them, they actually really do as nasty as melanoma, basically. You know, they can spread to lymph nodes, they spread to distant organs, they can cause death. So with that, I think I'm gonna switch gear to Mark's presentation. Let's see, I can unshare, right? Oh, I can just close it, stop sharing. All right, very good. Okay, great.
Okay,
Thank you.
so let me get mine here so I can. Okay, is that working for everyone? Or
Yes,
Kirsten,
that's good.
I guess no one else can say because just you. But is that showing okay?
Yes, that's great.
Okay. So thank you, Dr. Xu. Excellent presentation in terms of the appearance of melanoma, kind of early presentation. And again, thank you, Kirsten, for the invitation for the two of us and the opportunity to really raise awareness and go over some new insights and thoughts about melanoma. So the title of my presentation is What's New in Melanoma Care Today? And I'll try to develop a roadmap for you to really provide insights for ongoing progress in the melanoma clinic. So the objectives of my presentation are to both identify some practice-changing insights for treating patients with metastatic melanoma, and metastatic means melanoma that spread, and would also like to hopefully have you appreciate the potential of the immune system, our body's immune cells, to improve survival for patients with metastatic melanoma. To do this, I'm going to try to develop a roadmap in a melanoma clinic, and I'll try to take you on a journey as to how we've really made much progress, developed new insights, and are really helping more patients, and in fact curing some patients with melanoma once it's spread to distant sites. And like any roadmap, what I'll try to do is to identify the route, identify the members for the expedition. I'll try to describe what's needed for the journey and try to give a vision for using the roadmap. A few initial facts. The first, and as nicely described by Dr. Xu, early melanoma is curable. So again, when identified early, when managed early, when presented early, the vast majority of melanomas can be cured. Unfortunately, melanoma, once it spreads to distant sites, can be very serious and in fact can result in death. So like any journey, we need a starting point. And for melanoma that spread, so-called metastatic melanoma, and the treatment of metastatic melanoma, I'll take you back about 10 years. And at that point, the summary slide for melanoma is the one that I'm showing you. That metastatic melanoma is a bad disease. Median age around 50, median survival 6 to 10 months, and less than 5% of people living more than 5 years. Again, that was a short 10 years ago. That was a starting point. As to who's on the expedition, well, these are people who've got melanoma. And as Dr. Xu mentioned, this is a relatively common cancer. Projections for this current year in the United States, about 100,000 cases, somewhat more men than women, and about 6,800 deaths, again, somewhat more men than women. In terms of the destination are effective treatments with, in fact, potential to cure patients with advanced melanoma. So what's shown here is a crystal ball that was given to me many years ago, probably 25 years ago, from a patient of mine, actually from the spouse of a patient of mine, because my patient had passed. And what she gave me was a crystal ball. And she said, Dr. A, what I really hope is that in this crystal ball, you'll find insights to free others from this terrible disease that has caused so much pain and suffering and ultimately death of her husband. So I keep this crystal ball in my office every day. And really what's needed for the journey are insights to improve survival for patients with metastatic melanoma. So to help explain my metaphor, I'll give a few examples of a recent journey that I took. Again, this is a roadmap starting in Milwaukee, ending up in Door County, and this is for a bike trip with some of my kids. Shown here are members for the journey. Shown here is what's needed for the journey, some nourishment. We thought it was nourishment at the time anyways. So in terms of the melanoma journey, what's needed were new insights. And again, as mentioned, these are insights that started in the lab and found their way in the clinic and are helping many people, and in fact, curing some people with advanced metastatic melanoma. The two insights that I'll try to describe for you are shown here. One are so-called driver mutations in melanoma, and I'll explain that in the next slide. The second are what are called immune checkpoint blockade of melanoma, and I'll spend some time going over that concept as well. So the first insight, and again, these are things starting in the lab, studied intensely in the lab, and then investigated in the clinic. And this insight was that some melanomas have what are called targets for therapy. And to be a target for therapy, you need to find something in the cancer cell that's important for the cancer cell to grow. And in fact, that was identified. The so-called BRAF mutation is the one that's been characterized to the greatest extent, and that's a target. And about half of the melanomas have that target, and there are treatments that can be given. These are pills and combination pills that can attack what makes the melanoma grow. And when given, they can work, they can cause reduction, and sometimes even within days in terms of the growth of the cancer. One important point and one challenge is that for the targeted therapy to work, obviously the cancer has to have the target. So for the example I gave, the so-called BRAF mutation, about half of melanomas have that target, about half of them do not. But if the target's there, the treatments can in fact be quite rapidly effective. They can cause dramatic shrinkage. A patient I treated just a few weeks ago, within a couple decreased large painful nodules throughout her body. That's the positive. The negative is, as mentioned, the tumor has to have the target, so that doesn't apply to half of the patients with melanoma. The other negative is that while they work initially, they rarely work more than a year. So again, it's a great way to get some initial shrinkage. It's a great way to improve quality of life, even in fact extend some quantity of life, but uncommonly doesn't last for much longer than about a year. So a picture from the bike ride, the road's getting better, but still a ways to go. So the second insight, and this was really profound, is that immune cells, what are called T cells, can recognize melanoma as foreign. And I'll spend a few minutes on this slide because this is really impactful. This revolutionized how we care for patients with melanoma. And the same concept is now extended to patients with many other cancers, and in fact is helping patients with many other cancers as well. So shown here is what's called a T cell. This is one of our body's immune cells. These are better known as so-called infection fighters. So when patients get infections, when we get infections, our T cells get activated, they clear the infection, then they go back to a resting phase. What was discovered is that these T cells can interact with, recognize, and ultimately kill melanoma cells. They recognize them by very exquisite mechanisms. They see differences, so-called antigens on the tumor. They get activation signals. They interact through the so-called receptors, interact with and kill melanoma cells. And what was discovered is that some treatments can use this potential to fight against the cancer. And it worked quite well in the laboratory and even in various mouse models. One problem was recognized, and the problem is shown in this cartoon. And the melanoma fighting T cells are shown in yellow. All the other T cells are shown in green. And you can see the problem, that there weren't enough melanoma fighting cells to take care of the cancer. The solution was to find a way to get more of these melanoma fighting cells, to so-called release the brakes, to find some way to keep these T cells active so that we could take advantage of their potential to fight against the cancer. And the solution is what was called immune checkpoint blockade. That's a strategy that I'll show you in the next couple of slides to effectively take the brakes off the immune cells, to keep the immune cells activated, and let those immune cells, once activated, go and fight against the cancer. So as to how that works, I'll use the analogy of a car. So here's a car with the brakes and the accelerator. And in fact, what these treatments do, is the so-called immune checkpoint inhibitors, is cut the brakes. Think of your car on a hill. And what you want to do is get the car down past the stop sign and effectively get straight down the street. When that happens, these T cells that, as you saw, can interact with, can recognize, can specifically kill melanoma cells, we could then get them amplified, they could do the job, and they can eradicate and kill the melanoma cells. The downside is shown here, and that's what these treatments do, is cut the brakes on all the immune cells. So what we want to do is activate the melanoma-fighting immune cells, get that car down the road. The road's not always straight, though. And what these are so-called side effects, that the immune cells, once activated, can sometimes go off the road. They can sometimes hit normal cells. And what this causes are what are called immune-related side effects. They can cause colitis, attack the colon, dermatitis, attack the skin. Pretty much any organ in the body, an immune cell can go ahead and attack. So we've recognized this possibility and spent a lot of time in the clinic with our patients going over teaching in terms of, if you get unexplained diarrhea, you get unexplained cough, you get this unexplained rash, we need to know about it. And there are various interventions that can be given to try to cure the side effects. This intervention was really profound and resulted back in 2013 for cancer immunotherapy being called the breakthrough of the year. And this was initially learning how to use these immune cells to fight against the cancer, and then how to better understand and control the various side effects that can also occur. These advances also motivated me to write this commentary about a little over a year ago, calling The Age of Enlightenment in Melanoma Immunotherapy. I use, in this time, the analogy of the Age of Enlightenment with some new insights that were helping many patients. I spoke about the Dark Ages back about 10 years ago, where we had painfully few treatments. So we had many very deserving patients, some beautiful people, but very few treatments that could make an outcome difference in terms of their cancer. What we have now in the so-called Age of Enlightenment are some new insights, ways to use the immune cells, which are helping many people, and in fact, curing some people with advanced melanoma. So the road's getting better, but we're not quite there yet. And again, this is the route. It was a long bike ride, but the roadmap is there. And the roadmap, and I've really emphasized the roadmap and specific details here, because I think that's a key point, and one that I really hope I can communicate with this lecture, that transformative insights, some real new understanding in the lab can really guide progress in the clinic. So as to what we're trying at our cancer center to keep moving things forward, because as mentioned, we're helping many people, we're curing some people, but you can do the math. And if we're doing that, there's still many people who are not being helped, and too many people that are still dying with advanced melanoma. So there's two of the approaches in the lab and in the clinic that I want to describe for you. One involves a collaboration with colleagues in the UW School of Veterinary Medicine. We're trying to help dogs with melanoma. And again, I want to emphasize, we're not giving dogs melanoma. These are dogs that get spontaneous melanoma. These are pet dogs that also have a bad diagnosis. We're trying to help the dogs and then learn from this treatment to help inform our treatment for people. We're also trying to learn and investigate new strategies to activate better these anti-melanoma T cells in patients with melanoma. So here's a dog many of you, maybe all of you will recognize, does not have melanoma or did not have melanoma, Scout. If you saw the Super Bowl, you saw Scout. I think it was towards the end of the second quarter. And Scout had a rare type of cancer called hemangiosarcoma. I show Scout because he probably is the best known canine from our veterinary oncology school. Many of his colleagues, I call them colleagues, friends maybe, or at least other canines, have melanoma. And melanoma is the most common oral cancer in pet dogs. Average survival of pet dogs with melanoma is less than 6 months if the melanoma is spread. And what we're doing is looking at new treatments to help pet dogs with melanoma. And by doing that, we're doing blood tests and biopsies and hopefully learning from that approach to help our patients. We're also looking at studies in patients to better activate these immune cells. I mentioned we have ways of trying to cut the brakes on immune cells to make them more activated. And one of the problems that we see is the need for more of these anti-melanoma immune cells. If we had more of these anti-melanoma immune cells and then cut the brakes, we'd have a much better chance of eradicating the cancer. And this shows a clinical trial that we recently started. 2 patients have been accrued. And we're using an injection directly into the tumor nodule, trying to activate the tumor nodule to look foreign to the cell, to the person, to the self. And then ultimately we'll give this with radiation to hopefully make it a better vaccine. And then the so-called immune checkpoint inhibitors, the specific names are ipilimumab and nivolumab, to activate those activated cells. This is the same approach we're using in dogs. We're using it in people. We're studying the outcomes in the dogs to help us better understand what to do in the people. That study is now on an accrual hold because of the COVID-19 crisis, though. So our patients, the 2 who are already accrued, we kept on treating, but because of the intense monitoring and the intense testing required, we needed to put a pause on accrual for the same reason that we're doing this talk virtually instead of in person because of the COVID-19 pandemic. But hopefully we'll again start accrual soon. So I've tried to show you both melanoma, what's occurring now, and try to give a vision for the future. So this is percent survival. This is the chance of being alive. 100% is everyone's alive. 0 is no one's alive. This is basically where we were before with chemotherapy. Almost no one living long-term. And the curve with no treatment was not much different than this. With the so-called targeted therapy, the specific names, dabrafenib, trametinib, again, I left some of these names off because I felt that was perhaps not as important as the concepts. We're having people live longer. We're causing a rapid reduction in tumor shrinkage. But unfortunately, the cancer oftentimes gets resistant. Where we're at now are what are called immune checkpoint therapy, where some patients, and that percent can be anywhere from 20 to 30 to even 40% of patients, using some of our current combinations now in the clinic, are living long-term. And I used to never use the term C, which is for cancer, for cure, but I actually am now, in that some patients who are now 5 and 10 years out with cancer that's spread to many distant spots are, for all practical matters, even cured of the cancer. What we're trying to accomplish with a combination immunotherapy and checkpoint inhibitor is up here. And again, at the end of the day, we're trying to get more of these cancer-fighting cells, take advantage of the intense power of the immune system to then eradicate the cancer and have that happen for more people. So we're trying to get to the end of the journey. We actually all made it. And this is really a team accomplishment, both individuals in my lab, collaborators from our immunotherapy team, individuals with the clinical research team, individuals in our melanoma clinic, really all working together with the same goal. This also involves funding, both a merit grant, which is in fact supporting our canine study, a grant to my good friend and colleague, Paul Sondel, which is supporting our clinical trial, other pilot funding from the Cancer Center, and also philanthropy. And I cannot speak both kindly enough and strongly enough about the importance and the value of philanthropy. Anne's Hope has been a supporter for many years. Actually, we'll have a virtual run walk this coming Sunday. Luthol Foundation, Tim Eagle Memorial, and others. And my final slide as to why we're doing this, and that's really for melanoma patients for whom this work is dedicated. And while much progress has happened, And hopefully I've convinced you in these examples that where we were literally 10 years ago, and I've been doing this for 25. So for the last 10 years, we've seen tremendous progress. But you saw that last curve, and we're helping many people, we're curing some people, but many people are still in need of new advances, new insights. And for that reason, we need to go back to the roadmap. The roadmap's clear. We keep working in the lab. We keep getting new insights. We take those in the clinic, and we'll help more people and hopefully cure many more as well. So thank you.
Thank you so much, Dr. Albertini. I'm going to turn off our recording now and we can take questions from the group. So hang on just a second.